Prende così. En même temps, cercare, prende più.
Our place is that it seems like you're doing, but you're not speaking together, right? That's what the end.
Yeah. It's just one pound.
Yeah, that's great. So here's do you want to speak up or down?
I'll be there and I'll take my laptop because I need the screen and not continue on Zoom.
Yeah, great. So you see there's the controller there?
Yeah, I did. We tested that and we did a sound check.
Oh.
It's already in Zoom and I just need to look at my presentation for one last time.
That's fine. On va commencer dans 7 minutes. Il y a quelques places. Oh, on va commencer dans 7 minutes, mais il y a encore quelques places. Il y en a 2 ici. Il y en a 2 là. J'en vois une autre ici. 2 there.
2 more chairs in the front, so we could just move them to the back so 2 of you could sit. Actually, there's just one. Vincent, there's just one because there are 2 now. Sorry. I miscalculated. Yeah, but when Lynn is doing her presentation, I think I probably sit down, yeah. But
Well, as everybody is very comfortable right now, so thank you very much. I'm Dr. Vincent Dagenais-Beaulieu. I'm a pharmacist at the Jewish General Hospital, professor invité at the University of Montreal. So I'm co-chair of the pharmacotherapy sessions, which is today, right now will be the last session. So I'm very pleased to introduce Dr. Anna Christine Willert, which is a board-certified neurologist in the Department of Neurology in Charité, and this is German, Berlin Hospital. You can say the Universität Medizin. Well, that's my German. So her main clinical and research interests are in neuropalliative care, especially for patients with epilepsy and stroke, under the direction of Prof. Christoph Ploner and Alexander Krovsky. She played a key role in setting up the neuropalliative care ward at Charité Campus Avignon. And online, we also have Marilyn McPherson, which is a professor and executive director of graduate studies in palliative care, doctor in philosophy, master's in science, graduate certificates, and at the University of Maryland, Baltimore. McPherson has maintained her as a practice both in hospice. So here we go. We see her right now on the screen. She can't see us, unfortunately. So at the end. So at the end, the question part, she will be able to see how very packed we are and very cozy. So Dr. McPherson is particularly interested in opioid conversion calculations, I'm pretty sure you're aware, and the safe and effective use of medications in patients in life-limiting illness, ranging from drug selection, deprescribing, and risk mitigation. So we're in for a treat for seizures in end of life, the differential management. So please welcome my co-chair, I'm sorry, yes, my co-chair, Sarah Girard, who will be able to present herself right now. Yeah.
Ça fonctionne. Fait que bienvenue tout le monde. On est content que vous soyez autant enthousiastes que nous sur le sujet. And we hope you have a nice time.
Thank you very much.
So thank you very much for the very kind introduction. My name is Anna Willett, and I come from Germany, so I hope for two things. I hope my German accent isn't getting too much into the way, and I also hope that my presentation is not too European and that you can take something home. And I'm also very glad to do this talk together with my colleague Lynn, who will do the second half, and in the end, we'll go through a very quick and short clinical case just to give it some clinical implications too. To start with, I need to practice coordinating my laptop and the screen, so give me a second. So I don't have any conflict of interest to declare, and this is our learning perspective for the session. So I'm first going to talk about seizures and seizure classifications and epilepsy and how it's classified, because we neurologists love classifications and definitions, and I hope it's not getting too dry. We will also talk about how you can recognize a seizure, and I give you a very short overview over the general treatment, but I don't want to interfere in this topic too much because Lynn is going to talk about it. And of course, I'm going to talk about seizure and seizure management within palliative care, because that's where we're all working in. So let's start. Before we talk about epilepsy, we need to understand what a seizure is and how we classify and divide seizures. So, citing the International League Against Epilepsy, a seizure is defined as, or an epileptic seizure is defined as a transient occurrence of signs and/or symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain. So that's a very dry definition for a very distressing symptom. And when a seizure occurs, we have to ask ourselves what kind of seizure it is. Is it provoked? So is it a symptom of an acute other disease that we can treat so the seizures will stop? Like, for example, in systemic diseases like metabolic derangements, alcohol withdrawal, or intoxication, or probably also more familiar in neurology, is it probably a seizure within an acute brain injury, a trauma, or hypoxia, or whatever? Or is it, sorry, there's the coordination. Or is it unprovoked and does not have an acute cause, but probably occurs within the disease of epilepsy itself? And so there's two things. There's the provoked seizures, and then there's the unprovoked seizures that we have to think about when a seizure occurs. And then we need to classify the seizures and look at how a seizure started, because seizure classification starts with the onset of the seizure. We define it as focal, meaning starting in one hemisphere, or it being generalized, so taking place in both hemispheres, and also, for example, showing convulsions in both sides of the body. Or we don't know how it started, so we call it unknown start. When we are talking about focal seizures, we can also ask ourselves, is the patient aware of the seizure? Can he probably describe what has happened, or is he not aware? Then we say it's a motor seizure or a non-motor focal seizure, taking these descriptions that I listed on here, but we are not going into greater detail because we don't have enough time. And we have generalized seizures, meaning that the person is not aware because we have a seizure taking place in both hemispheres of the brain. It also can be a motor appearance, can have a motor appearance, or it can be non-motor. Like the most well-known seizure might be the tonic-clonic one. And then, of course, there's unknown seizure types, which can also be motor or non-motor. So when we're not sure whether there was a seizure or when we observe a seizure and it stopped, there are several signs that I want to draw your attention to which are post-ictal, which means that they occur after a seizure took place and which can be observed and also described, for example, by the relatives. And they can help us to divide seizures from, or epileptic seizures from, for example, non-epileptic seizures. So a person who has experienced a non-aware generalized seizure, for example, might show signs of drowsiness afterwards, a tongue bite, which typically is at the side of the tongue and not at the tip, and probably also have incontinence for stool or urine. And there are a lot of other signs as well that are listed here, but I'm not going to talk about them. So now we have classified seizures. Now we can talk about epilepsy, because epilepsy is, oh, sorry, slide change, yes, sorry, oh gosh. So there are the signs. And now we can talk about epilepsy.
Change the slides.
Yeah, great. So I don't have to do three things at a time. Thank you. So now we can talk about epilepsy. When we talk about epilepsy, and this is again a boring quote, but it's important to know what the International League Against Epilepsy says about it. So epilepsy is a disorder of the brain characterized by an enduring predisposition to generate epileptic seizures. And when we talk about epileptic seizures in this case, we're talking about unprovoked seizures. So this is the case if at least 2 unprovoked seizures take place in more than 24 hours. So having 2 seizures within 24 hours doesn't give us the diagnosis. But if we have 1 seizure and then another seizure after at least 1 day, and there's obviously no acute cause, we can call it epilepsy. Or if there's 1 seizure and the risk to have another seizure within the next 10 years, this is very theoretical, is more than 60%. So when is this the case? This is the case when we see in the EEG signs of seizure activity, or if we look at the MRI and we probably see an old stroke, or which affects the cortex, for example, or we see a brain tumor or whatever. Or, and I'm not going to talk about it in detail, or there are symptoms and signs of an epilepsy syndrome. In this case, we can diagnose epilepsy. Oops, sorry.
I'm following.
Great. And I want to make a very short note on this, because we talked about seizures, and what we do is we don't treat every seizure that occurs, but we do acutely. But what we do is when we have the diagnosis of epilepsy, we have the indication for anti-seizure medication. Some people also say anticonvulsants, or what kind of word you might be familiar with, but epileptologists now talk about anti-seizure medication. So this is a set term, and I'll stick to that. So the recommended choice of anti-seizure medication depends on the type of epilepsy and also sometimes on the gender. So this is just a short footnote. Epilepsy is not just one disease. In fact, it's a huge variety of diseases caused by a very broad spectrum of etiologies. So we have structural causes, we have genetic causes, infectious diseases, metabolic reasons, or immune or autoimmune reasons to have an epilepsy. This makes it very difficult to actually talk about epilepsy, because also the prognosis varies. But this is just also a footnote. And we have to consider the comorbidities when talking about epilepsy, because there's a very complex interplay of comorbidities, epilepsy, their etiology, and treatment. Before I will go into greater detail of how epilepsy affects people. Let me just quickly talk about the one emergency you might be familiar with that could take within epilepsy, or could also be an acute symptomatic emergency within other acute brain injuries, for example, and this is status epilepticus. A status is defined as an abnormal prolonged seizure. Now, when is a seizure abnormally prolonged? That depends on whether it's a focal seizure or whether it's a generalized seizure, because we define or we look at the time points when the brain gets severe damage from the status. But for the clinic and our practice in clinic and our daily business, you can take home the number 5 minutes, because that's when we want to start treating the status, after 5 minutes, no matter what it looks like, and not before. That can be a very long time. So after these 5 minutes, we start applying medication. And here is just a very short overview of how treatment would look like in a generalized convulsive status epilepticus, because we would treat focal status a little bit less aggressive. But when it's generalized, you want to have a very aggressive treatment, which has 3 levels depending on when it stops. So this was the neurological part, and now I'm putting on my palliative care goggles and look on epilepsy from a palliative care point of view. Because when you look at epilepsies, we already talked about how they differ and how also prognosis can differ. And we also talked about the complex interplay of comorbidities, etiology, seizures, and stuff like that. And when you do that, you realize that people with epilepsy actually do experience multi-layered suffering. They have symptoms on every layer of suffering that we know in palliative care. They have physical symptoms. They don't only suffer from seizures, they also suffer from injuries caused by seizures. They suffer from comorbidities that also might affect the seizures. On a psychological level, they have depression, or they could have depression, which again could also worsen epilepsy. They have huge anxieties. On a social level, epilepsy is still stigmatized, so they suffer from that. There might be isolation, underemployment, or difficulties within the family dynamics. And also on the spiritual level, they experience chance, randomness, or unpredictability. There's struggle and self-assertion. So we have this multidimensional symptom burden that we might find in people with epilepsy. So we introduced this concept of total pain to epilepsy and called it total seizure to conceptualize how it might affect people who suffer from epilepsy and refractory epilepsy. But now we are palliative care physicians, professionals, nurses, and I hope I didn't miss anyone at this point. So I want to draw your attention to, or probably remind you or talk to you about the meaning of epileptic seizures and epilepsy within palliative care, and also the end of life. So we are all familiar to the palliative situation, and this is something that really makes a difference when we treat epilepsy and seizures, because we have an advanced disease in most of the cases. So we have a change in goals of cares, and we also might have a limit situation, not only for the patients and their families, but also for the professional team. And in my understanding, seizures are a relevant symptom within palliative care. They affect people with brain tumors. they affect people more with primary than with secondary brain tumors. For example, more than or up to 90% of people with gliomas experience a seizure throughout their disease course, with astrocytomas, of course, being far more epileptogenic than glioblastomas, who grow more slow. And also, when you ask the German palliative care physicians how often they are confronted with people who experience seizures, they would say approximately 1/8 of their patients who are they treating experience seizures within a palliative care structure. And seizures also cause crisis. They cause distress. They are a common cause for hospitalization, also at the end of life, which we also saw when we looked at our cohort of neuropalliative care patients where I work. We saw that the most common reason for people who have palliative care needs in neurology present to the emergency room because of a seizure. And it's also, and this is now not highlighted anymore, but a common indication also for palliative sedation therapy at the end of life, although we don't really know how often that takes place, because we don't have data to that. Or if you do, you can send it to me. I would be happy about that. And seizures also are challenging. They're challenging because we sometimes have the problem that we want to maintain autonomy, cognition, and consciousness at the end of life, but seizures still occur and we need something to stop them. And there are also challenging symptoms like dysphagia and disturbance of consciousness, who often or most often occur, for example, in the last days of glioblastoma patients or other brain tumor patients. When you ask, also I asked my colleagues in palliative care in Germany what they think is challenging in treating seizures and epilepsy within palliative care, and they define 4 categories where they think there are challenging aspects to it. First, the seizures themselves, obviously, like for example, there's insecurity about whether there should be diagnostics after a first seizure when there's a palliative care patient at home, for example. They were unsure about the emergency management of status within, for example, hospice setting. Also on the level of the anti-seizure medication, there were insecurities like questions like, shall we continue anti-seizure medication in the dying phase or shall we stop? Within the professional team, they also said palliative care professionals are often unsure of how to handle anticonvulsants, so anti-seizure medication, or recognizing certain seizure patterns. And also on the family level, they saw a lot of fear and overburdening when a seizure takes place. So probably these are international problems, but we just did the survey in Germany, so I can't generalize, but these are defined by German colleagues. So time is almost up, so I'm gonna briefly finish with talking a little bit about anti-seizure medication and palliative care, but not too much in detail because Lynn is giving her talk just in a few minutes. But let me talk about the principles and also the influencing factors. When we start or when we treat people with seizures, we of course first have to ask ourselves what type of seizure and epilepsy there is. In palliative care, at least in palliative care for adults where I work in, we mostly have patients with focal epilepsy, so brain tumor patients. So we need to ask ourselves this. Then, of course, it's important to have a look at the stage of disease and the prognosis, because that might influence our choice of anti-seizure medication. If we have, for example, an astrocytoma patient with quite a mediocre life expectancy, we would probably go for a medication that is not so flexible, like lamotrigine. But if we have a glioblastoma patient where we know that he is his or her life expectancy isn't that long, we would probably choose something where we are more flexible to handle in case of dysphagia or disturbance of consciousness. Then patient-centered goals of care, as always, in palliative care, that's very important. So where are the priorities? How distressed is the family when there is a seizure? Can they manage it by themselves? Which also leads us to the fourth aspect, the place of care, which has an impact on anti-seizure medication and the choice. Because it has to be practicable, it has to be flexible. We need to think of routes of administration. And this is a short overview also of different types of routes of administration that could use. Most of them are off-label. Some of them are also experimental. And I just highlighted the three important medications for focal epilepsy. And when you ask, again, the German colleagues, what they mostly use, they say they mostly use levetiracetam and midazolam for their patients. And when you look at the flexibility and the probable routes of administration, you know why. Talking about end of life, I hope I won't give you too many questions rather than answers, because we don't really know a lot about how to handle seizures in the dying phase. But first thing is, a seizure, of course, is a burdensome symptom, so we would like to treat or prevent it. Still, there are open questions about continuation of anti-seizure medication in the dying phase. So is it better to change the route of administration, or is it better to rotate to benzodiazepines? Is it okay for the patient to have it on demand, or is it better if we give it continuously? These are all questions and are answered on a very individual base. So I just leave you with these questions and I hope that's okay for you. So to sum it up and conclude, I think, first of all, I thank you very much that you all attended, and I'm very overwhelmed by the crowd, also in the back standing there. For me, as a neurologist and palliative care physician, seizures are an important symptom, although I'm aware it might be rare. But when there is a seizure, it can cause acute crisis, so we better control and treat it.
Thank you.
Do the Q&A in the end, or shall we?
No, Q&A at the end. So now we will enjoy Marilyn McPherson speech. So now, Marilyn, I will click. Oh, that's great. We have you besides one another. So we see you and we see your slides.
Okay. That's quite a deal there. So thank you for having me. I'm sorry I couldn't be with you in person, but for the last 2 days I was in Texas and just got home late last night. If you could go to the next slide, please. And so I'm going to do the middle objective, the pharmacokinetics and pharmacodynamics of at least the most common drugs for epilepsy, which brings us to this slide. So what do we call these drugs? Some people call them anti-epileptics. They could be anti-seizure, anticonvulsant. I don't really care what you call it, but you know, we're all referring to the same thing. And I think this is interesting. When you look, if they're used appropriately for the correct seizure, whether or not it's FDA indicated, because I come from the US, of course, they're roughly equivalent in efficiency and efficacy. So how do we choose a drug? And I just went over a little bit of this. And I do think that at end of life, it kind of is a different ballgame. I work mostly in home hospice care, which really, we don't have a tremendous amount of options, but it does depend on the seizure type, how easy it is to use it. That's really important in home hospice. I mean, these patients often can't even swallow. And I think midazolam is an awesome drug too, but it's not something we have hanging around in a patient's home, generally speaking. So the spectrum of activity, the adverse effects, I think This group of drugs is just rife with adverse effects, obviously. And drug interactions, they could be the poster child group of drugs for drug interactions. Looking at comorbid conditions and suitability for older adults because they're more sensitive to the effects of these drugs. Generally speaking, you begin with a single drug, you keep increasing the dose until you either achieve efficacy or side effects emerge and become unacceptable. Most guidance says you should, if it doesn't work sufficiently, try a second or maybe even a third drug as monotherapy before considering the use of two drugs at the same time. Next, please. So some are approved as monotherapy. This is just one set of guidance for what's the best drug for what kind of seizure. So some are approved as monotherapy, many of them as adjunctive therapy, but then in addition, they could be monotherapy for other types of seizures. I think it's worth noting that it's really hard to do research with monotherapy in anticonvulsant therapy. For one thing, the placebo group, I think, is kind of almost unethical if you have somebody who's actively having seizures. And someone who is controlled on monotherapy is going to be very reluctant to give up their drug of choice that's working to maybe get placebo or maybe try the new kid on the block. Next. So the rest of my slides are not edge of the seat stuff. It's really just the facts, ma'am. I guess you'd have to be of a certain age and from the US to understand that reference from an old TV show. But I'm going to go through each of the drugs and try to hit the high points here. So brivaracetam is an analog, of course, of levetiracetam. And it's FDA approved, at least in the US, of course, for focal onset seizures in patients over a month. It can be effective as add-on therapy in adults with refractory focal seizures. And like levetiracetam, it can also be effective in other seizures as shown here. Adverse effects, somnolence, dizziness, fatigue, nausea, and vomiting. And also you can see psychiatric adverse effects, like particularly anxiety and depression, but it's unclear if that prevalence is greater than or less than levetiracetam. Drug interactions, it is metabolized by the 2C19. Most of the drugs, most of the anticonvulsants are handled by the cytochrome P450 system, which, as you know, that is the basis for metabolic drug interactions, and they have a lot of them. So co-administration of a 2C19 inducer like rifampin would significantly reduce the serum levels of this drug. And this drug is going to increase phenytoin levels and the active metabolite of carbamazepine. So it is subject to changes in metabolism also for people who have genetic polymorphisms at the 2C19 enzyme. I've listed the dose and I'm going to try to give the prices, at least in the US, for as many as I can. So as you can see, this drug is not a cheap date, $1,400 a month. Next slide, please. Clonazepam. This actually was the first benzodiazepine used for epilepsy. It does have a higher affinity for the GABA A receptor than diazepam. It is approved for the treatment of Lennox-Gastaut syndrome and myoclonic and atonic seizures, used to treat other seizures as shown here, but less effective than ethosuximide or valproate. Also, it's used quite a bit, at least where I come from, to treat panic disorders and anxiety disorders. Unsurprising, the side effects, drowsiness, ataxia, behavioral disturbances. Just yesterday, I was talking to a hospice nurse about a young man with Batten syndrome, which I had actually never heard of. And he has total body aches. And we were using the clonazepam for the very tight muscle spasms that he was having. But then it also made him psychotic. So you're kind of, running on the razor's edge there. Which way do you go with that? So the adverse effects, again, sedation, even at low doses, children seem to tolerate it better than adults. And this is a generic drug, so less than $50 a month. Next, please. Cenobamate. This mechanism is not really clearly understood, but we know it inhibits the sodium channels, and it's an allosteric modulator of the GABA A ion channel, acting on the non-benzodiazepine binding sites. So it was approved by the FDA in 2020 for focal onset seizures in adults. But what's interesting is it can reduce the median monthly seizure frequency by 55% in patients who are uncontrolled on another anticonvulsant drug. So sounds like it's a really good second-line drug. Adverse effects, same things we've been seeing. Interestingly, it can cause serious skin reactions, including this dermatologic condition, which can be fatal. You can see cognitive dysfunction and QT shortening. Lots of drug interactions here. This drug is an inducer of the CYP2B6 2C8 and the 3A4. So a couple of observations here. 2B6 as well as 2D6, which is not involved with this drug, are the two enzymes that are most subject to genetic variability. And 3A4 is our workhorse enzyme. 3A4 metabolizes probably 50 or 60% of the drugs that we have on the market. Also, this drug is a moderate inhibitor at the 2C19, so it's going to increase clobazam levels if the patient's also on that. And we can see a pharmacodynamic drug interaction with glucosamine due to the similar mechanism of action. So as you can see, this is not a cheap date, $1,180 a month. Next. So this is an oldie but a goodie. Carbamazepine, Tegretol was the original trade name in the US. This was the first drug approved for a neuropathic pain state, at least in the US, for trigeminal neuralgia. So for seizures, well, for the mechanism of action, it blocks the sodium channels, but although it can exacerbate absence or myoclonic seizures, it's effective for the focal and focal to bilateral tonic-clonic. Drug interactions, again, this is kind of crazy how carbamazepine is metabolized. It is metabolized by the cytochrome 3A4, but it also induces a lot of enzymes, the 2B6, the 2C8, and the 3A4. So it's metabolized by 3A4, but it induces 3A4. So it auto-induces its own metabolism. So when you start the drug, you have to start lower, and then each week for about a month, you have to keep increasing the dose so that you can get to a therapeutic level. Another important tip is you don't want to store this drug in humid conditions because it can cause concretion. What is this? It's a hard, solid mass. So it's a big glob that's hardened of the tablet. So obviously you have very poor bioavailability and therapeutic failure. So where in the house might we have humid conditions? The bathroom and the kitchen. Where do most people store their drugs? In the bathroom and the kitchen. So not a good idea. I would move on. Adverse effects, you can see drowsiness, blurred vision, double vision, headache, dizziness, and so forth. Also, you can see in 5 to 10% of patients an increase in their liver enzymes. So we do have to be careful with all those drug interactions, and also a rash, because especially if you start at a high starting dose or you escalate too quickly, you can see Stevens-Johnson's or toxic epidermal necrolysis, and also you can see DRESS, the drug reaction with eosinophilia and systemic symptoms, which can be fatal. This is generic, so it's pretty inexpensive, but we may have an XR, extended release formulation that would be more costly. Next, please. Eslicarbazine. Actually, the drug is eslicarbazine acetate, which is very rapidly converted to eslicarbazine, which is also, interestingly, the active enantiomer of oxcarbazepine. So very related drug. So if you look at oxcarbazepine and you hold the molecule up to the mirror, when you see the mirror image, you're going to see the R and the L enantiomers. So their carbon copies just flip backwards. So this is half of the oxcarbazepine molecule. So obviously, eslicarbazine, oxcarbazepine, and carbamazepine are structurally similar, but they do differ in pharmacokinetic and pharmacodynamic properties. It's approved as monotherapy and adjunctive therapy for focal onset in children over 4. Adverse effects, very similar to what we've been seeing. We can see the serious adverse effects of hyponatremia and the derm reactions. And of course, drug interactions. It induces 3A4 and it inhibits 2C19. So it can increase clobazam levels, omeprazole, and reduce simvastatin. And several of the anticonvulsants, those that are metabolized by 2C19, can jazz up the metabolism of oral contraceptives, which I think is a pretty darn important patient counseling point, and also warfarin. Carbamazepine can reduce the serum concentration, and you're not supposed to give it with oxcarbazepine. This drug is $1,270 a month in the US. Next, please. Ethosuximide, also an old drug. It's approved by the FDA for absence seizure, not effective in focal onset or generalized onset tonic-clonic. It's usually pretty well tolerated. It's got a really long elimination half-life, about 60 hours in adults, 30 hours in children. The adverse effects, a lot of GI, nausea, vomiting, and the CNS, lethargy. You can see hiccups, headache, psychotic behavior, hematologic abnormalities, and the whole derm parade as well as SLE. Drug interactions, it is partially metabolized by 3A4, so we do have to worry about other drugs that are inducers and inhibitors because they can absolutely affect the ethosuximide level. This is a generic drug, so it's very inexpensive. Next. So if you have not heard of gabapentin, you must have been off the planet or something. I think this is the #1 drug in the world for neuropathic pain. So we might as well just go ahead and put it in public water. This drug has little or no action on the GABA receptor. It binds to the alpha-2 delta subunits in the calcium channels. As you can see, it's FDA approved for adjunctive treatment of focal onset seizures and focal to bilateral tonic-clonic. I will say that it is used for 80 million indications, at least where I come from. And I will say that the drug company was probably being a little too aggressive in sharing the love about how else we could use gabapentin. And they had to pay quite a large penalty fine for doing that. So lots of off-label uses. So certainly, and also there are several formulations in the US that do have different indications. Absorption is dose dependent. This is really important with gabapentin. For one thing, I think the dosing is really important. So a lot of prescribers will start a little old lady off for neuropathic pain, at least at like 300 3 times a day. That dose could drop a moose, let alone a little old lady. So if it's an older person, sometimes I would recommend starting off at 100 milligrams at bedtime. And then as soon as they're not sedated with that hangover sedation in the morning, then go ahead and go to BID and then go to TID. But as you increase the dose of gabapentin, the bioavailability decreases. So when you get up to those large doses, like going from 2,400 to 3,600 milligrams, you did not increase the patient's dose by 1,200 milligrams. Also, we have FDA approval for postherpetic neuralgia. That's actually the only pain state I believe it's approved for. And then we have a different formulation. It's a prodrug. It's gabapentin anacarbol, which is trade name is Horizont. That's approved for restless leg syndrome, and that does not have this has dose proportion exposure. So as you increase the dose of the gabapentin anacarbol, you don't have that reduction in bioavailability. How do people feel when they start gabapentin? Well, they feel like a drunk monkey. So somnolence, dizziness, ataxia, they really feel very ataxic, fatigue, nystagmus, and so forth. You can see weight gain, and I think sometimes that is due to the edema, and you can see movement disorders and behavioral change. Now, in the US, there's been some excellent data showing that this drug is very often misused and abused. There also is a very close correlation, a dose-related effect, speaking of adverse effects, where gabapentin suppresses the minute volume. So the higher the dose, the more likelihood of causing respiratory depression. Drug interactions, this is the good news of gabapentin. It does not induce or inhibit any of the liver microsomal enzymes. And be careful, don't give it with magnesium or aluminum hydroxide. That will reduce the absorption. Very inexpensive because it's generic. Next. Next is lacosamide. This one has a very novel mechanism of action, modulation of the voltage-gated sodium channels by selective enhancement of slow inactivation, but without inactivation of the fast inactivation gateway. That's kind of a mouthful there, isn't it? The FDA approved it's for monotherapy or for add-on in patients over a month old with focal onset and adjunctively over 4 years old with general onset tonic-clonic. The adverse effects, again, very similar, dizziness, headache, some GI effects there. It is a Schedule 5 due to reports of euphoria. I just don't understand why somebody would, want to, especially with like gabapentin, which is so sedating. I guess people just like that medicine head feeling. You can see a small dose-dependent effect on the PR interval, and we can see pharmacodynamic drug interactions with cenobamate due to the similar mechanism of action and consequently increased adverse effects. Now, it is both a substrate, meaning it is acted on, but it's metabolized by 2C19, but it also is an inhibitor of 2C19. But this is not like carbamazepine, where it affects the enzyme that it's metabolized by. This drug really has no clinically significant drug interactions. I will point out that they have seen fetal developmental toxicity in rats. We don't have any human data. If you're using the regular old tablet, it's generic, it's very inexpensive. If you use the trade name, it's $1,100 a month. Next. Lamotrigine, this is a triazine compound chemically unrelated to any of the other antidepressants. It blocks sodium voltage-dependent channel conductance, and as you can see, the FDA approval, including the Lennox-Gastaut syndrome. It's also approved for conversion of monotherapy in patients over 16 with focal seizures who have received carbamazepine, phenytoin, phenobarbital, primidone, or valproate. And also it's been shown to improve depression in some patients with epilepsy. We occasionally use it for neuropathic pain as well. Less effective than ethosuximide or valproic acid in children with absence seizures, but better tolerated. And the side effects, unsurprising there. Interestingly, despite this laundry list that I have here, it does actually seem to produce fewer CNS adverse effects compared to many of the other drugs. Also, if you give it with valproic acid, this could be problematic. It prolongs the half-life of lamotrigine, which can also increase the risk of developing an allergic skin reaction. And you can see with this drug as well, the severe rash, especially if it's given in combination with valproic acid. Also, there have been 500 cases of documented pregnancy exposures with no overall risk of fetal abnormalities noted. And this is thought to be a good drug for the elderly because of the reduction in CNS adverse effects. Similarly, again, the generic formulation is very inexpensive. The XR is about $1,000 a month. Next. Oh my goodness, levetiracetam. I really do think we should put this drug in public water. Very, very popular. The FDA approved indication over a month old with focal onset and adjunctively for other seizure types. It is commonly used as monotherapy for these seizure types. I see it used a lot off-label, and our case we'll be discussing next, particularly when a patient comes home onto hospice care with a brain tumor or mets to the brain and they've not even had a seizure. Generally, they come home and leave levetiracetam. You can see some side effects, but they're pretty well tolerated. This drug is pretty well tolerated, and you really don't see drug interactions. So prescribers consider this a pretty clean drug. It's pretty well tolerated. The generic is very inexpensive. The extended release is about $800 a month. Next, please. Oxcarbazepine is a sodium channel blocker. Structurally, obviously, it is similar to carbamazepine, but it causes less induction of those hepatic enzymes, and it does not induce its own metabolism. So it's FDA approved for the treatment of focal onset seizures as monotherapy in children 4 and older, and adjunctively in patients 2 and older. And then we also have an extended release formulation, and it's effective in other seizures. Adverse effects, as you can see here, the same kind of things, the CNS effects and also the derm reactions. And you can see cross-reactivity with carbamazepine in 20 to 30% of patients. So if someone's complaining of a history of an allergy, I would take that seriously. Drug interaction, it induces the 3A, 4, and 5 isoenzymes, and it inhibits the 2C19. So don't forget 2C19, I always worry about the oral contraceptives. Generically inexpensive, the XR formulation is about $1,400 a month. Next, please. Perampanel is FDA approved for the treatment of focal onset seizures in children over 4 and adjunctively for generalized onset tonic-clonic. It's an antagonist at the AMPA glutamate receptor, so that's kind of an interesting mechanism. Similar adverse effects. You can see serious psychological, psychiatric, and behavioral effects, including irritability, aggression, anger, anxiety. And of course, we always worry about suicidal thoughts pretty much with the whole group of drugs. It's a C3, it's a controlled substance in the US due to the seriousness of the psychiatric and behavioral adverse effects. And drug interactions, it is partially metabolized by 3A4, just in fair or to small part, and the serum levels can, of course, be influenced by inhibitors or inducers. This drug is about $1,300 a month. Next. So phenytoin, my girl phenytoin. As a pharmacist, I hop up and down with excitement when we talk about phenytoin because it's so interesting from a pharmacokinetic perspective. This drug's a sodium channel blocker, and it can also inhibit the calcium channels. It's a very old drug, obviously, a first generation. It is as effective as carbamazepine for the treatment of focal onset and focal to bilateral tonic-clonic. But because she's such a naughty kitten, she's really not the drug of choice because the kinetics, while wildly fascinating to me, are kind of a pain in the neck to deal with. Also, we see different formulations. We certainly have tablets. We have the Infa tablets, which are chewable, which is plain old phenytoin. Then we have the capsules, which are phenytoin sodium. So phenytoin sodium 92 milligrams equals 100 milligrams of the phenytoin without the salt involved. And you would think, okay, 8 milligrams difference out of 100, how big of a deal could that be? But because this drug exhibits Michaelis-Menten pharmacokinetics, meaning those enzymes that metabolize this drug are highly saturable. And when you hit that flash point, your serum level can just go through the roof. It's really crazy how that works. And of course, phosphophenytoin is related. This is the parenteral formulation. It's a prodrug of phenytoin, and it's less toxic. Adverse effects, you can see nystagmus even in the therapeutic range. So let's talk about the therapeutic range for a minute. So it's thought to be 10 to 20 mics per mil, but here's the kicker. Phenytoin is 90% bound to albumin if a patient has a normal albumin. But I work in hospice, and probably 20% of our patients carry the diagnosis of malnutrition. So if they are on phenytoin, I think it's better to get, I mean, at least in our country, you can get a total phenytoin level and an unbound level. So really, your therapeutic range is an unbound phenytoin of 1 to 2 mics per mil. So that's really important. It can interfere with cognitive function related to learning, cerebellar atrophy, some of the derm reactions also, megaloblastic anemia, lupus-like syndrome, peripheral neuropathy, and so forth and so on. This is metabolized extensively by the 2C9 and the 2C19, and it's a very strong enzyme inducer. So I would say it's not used as often anymore. You can also use it for neuropathic pain, but I don't see this as a big player because it's such a pain in the neck to dose. Next, please. Pregabalin, I actually prefer pregabalin over gabapentin, at least for neuropathic pain. It's a GABA analog also. It has anticonvulsant, of course, and anxiolytic activities, anti-anxiolytic. It's approved by the FDA for adjunctive treatment of focal onset seizures over 1 month, and very similar mechanism to gabapentin and similar efficacy. The reason I like it better than gabapentin is with gabapentin, as I was saying, you have to start so low and titrate fairly slowly, particularly in older adults. But with pregabalin, you can start at like 50 TID, 75 BID, and you can push the dose. It has the exact same side effects in the exact same prevalence of about 40%, the drunk monkey syndrome, but you can get to your target dose in about a week with pregabalin. So I'm glad that it's generic now. It's about $4 a month. The trade name is still, of course, quite expensive. Next, please. Rufinamide. Boy, wait till I tell you the price of this one. It's going to knock your hat in the creek. This drug is structurally unrelated to the other anti-epileptic drugs. As you can see, it's approved as adjunctive treatment for Lennox-Gastaut syndrome. It's also effective for tonic-clonic seizures, effective adjunctively for refractory focal. Adverse effects, somnolence and vomiting, others as shown here. And it is a mild inducer of the 3A4. The price, the generic price is $720 a month. The trade is $6,335 a month. When I read that, I almost had a seizure. Next, please. Topiramate, Topamax, although the people I know who take it call it Dopamax for obvious reasons. The very potent anti-epileptic drug with multiple mechanisms of action, inhibiting the sodium channel, and it enhances GABA and inhibits the AMPA receptor as well. So you can see the FDA-approved indication, either as monotherapy or adjunctive therapy. Also can be used for atonic seizures. Also, it is in the US approved by the FDA for migraine prophylaxis. And that's where I see people saying, I just can't function on this drug. I can't see straight. I've forgotten my name. So ataxia is the most common. You can see impaired concentration, confusion, dizziness, fatigue, paresthesias in the extremities. It can disrupt memory and so forth. So it's kind of a pain in the neck drug from that perspective. It's a mild inducer of 3A4, an inhibitor of 2C19, again with the oral contraceptives. And when given with valproic acid, you can see changes in the ammonia and hypothermia. Next. Speaking of valproic acid or valproate, it's a very commonly used anti-epileptic drug. It enhances GABA at higher doses. It is 90% protein bound also. Again, a very old drug. I would say I see this drug in my population being used way more as a mood stabilizer and in patients who have agitation. I mean, we could talk all day long about how to manage agitated type behavior. I mean, the antipsychotics have really fallen out of favor. So my go-to is valproic acid. But as you can see, it has many indications for seizures. There is an extended release, it's a once a day, but it is not bioequivalent to the older formulation. So you have to increase the dose by 8 to 20%. Also approved, again, this drug for migraine and bipolar. Next. And these are the adverse effects, usually pretty mild. Mild and transient, minimal adverse cognitive effects. You can see nausea and vomiting, but it can be minimized by using the Depakote, the enteric-coated formulation. Also take it with food and titrate it slowly. You can see weight gain is associated with polycystic ovarian syndrome and other hormonal type influences. And you can see serious adverse effects, although they're pretty uncommon. It doesn't have as many drug interactions as the others. You can see hepatic enzyme inducing effects, increasing valproic acid clearance, and carbapenem, the antibiotic, can reduce the serum concentration. Also, interestingly, fun fact, this drug can cause hair loss and hair curling. Maybe I'll take it. It's better than a perm. Next, please. Zonisamide. This is chemically also unrelated to other anti-epileptic drugs. It blocks the sodium and the calcium channels, approved by the FDA for the treatment of focal onset seizures, but it really has a broad spectrum of activity. We have a lot of experience with this drug worldwide, particularly in children, as monotherapy and other seizure types. And we do use it also for migraine prophylaxis and weight loss, although it's not FDA approved for that. You can see the adverse effects, very similar, including the derm reactions, a lot of psych reactions, word finding difficulty. It is metabolized by the cytochrome P450 system, and then it's glucuronidated. So it's metabolized by 3A4 and 3A4 inhibitors, which are going to be things like grapefruit juice and ketoconazole and so forth, can decrease the serum level, and inhibitors can increase it. Those would be the inhibitors. Very effective for myoclonus, especially in juvenile myoclonic epilepsy, but spontaneous abortions and congenital abnormalities have been reported at a rate of about 7%, which is double the general population. The generic, very inexpensive. The trade name is about $700 a month. Next slide. And this is my last slide on the drugs. This is the other list, cannabidiol. In the US, we have Epidiolex approved for Lennox-Gastaut syndrome and Dravet syndrome. Felbamate is a very potent anti-epileptic. It can cause hepatic failure and aplastic anemia. Fenfluramine, indicated for Dravet syndrome over 2 years old. Ganaloxone is a GABA receptor modulator. Phenobarbital and primidone. So of course, primidone is metabolized to phenobarbital. Very strong enzyme inducers. So very potent drugs. They have a broad spectrum and a huge effect on inducing those liver enzymes. Stiripentol is used to treat Dravet syndrome in kids over 2, tiagabine and viagabrine. So those are the other drugs. Anna, I'd like to turn it back to you so we can talk about the case.
Great, thank you very much. Now, back to what we do in our daily practice and in our clinical work. I brought you an imaginary patient, Mr. G, we'll call him. And Mr. G is 65 years old, and he experiences a clumsiness in his right hand, which is why he goes to see his doctor, and he is given an MRI of the brain where one can see a mass in the left superior temporal lobe. It's solid, it has enhancing components and also necrotic areas, and it also shows moderate edema. He receives maximal safe resection, and to just jump right into the problem, pathology reveals a glioblastoma of a wild type, and the MGMT methylation status is negative. So, should Mr. G receive anti-seizure medication at this point? No. There is no or patients who are newly diagnosed with brain tumors, although they have a high risk of experiencing seizures throughout the disease course, there's up to date no recommendation to start them on seizure medication right away just because they have a tumor in the brain. So we would not start him on anti-seizure medication. Now, he also gets some other therapies. He gets radiation therapy and also temozolomide. What would you call this in English? Yeah, okay, sorry. And his Karnofsky index declines a little bit throughout this, and especially after operation. And then in the disease course, after he has finished his tumor-specific therapy, his wife describes an event that took place in one evening in May 2024. So his wife would describe what had happened, and I'm going to read it to you. First, I noticed a twitch on the right corner of his mouth, and then his right arm started to stiffen. Within seconds, his whole body stiffened, then arms and legs started shaking. His eyes were open and directed upwards to the right, looking into space. He made rhythmic snoring, breathing noises. Then it stopped and he just went limp. He was breathing heavily but would not wake up. His right arm and legs were paralyzed. Eventually he started to waken up again, but he looked confused and exhausted. His speech was slurred and it took hours before he could move the right side of his body again. So this is a very typical description of we would call a first focal to bilateral tonic-clonic seizure, showing all signs that you can see with the postictal phase also described nicely. With this seizure taking place and the diagnosis of glioblastoma, which was treated, but still there are epileptic focuses in his brain, one could diagnose Mr. G with focal epilepsy. So now that he experienced this first seizure, he gets a new MRI taken in May, and due to how things went, one could see multifocal recurrent masses in the left superior temporal lobe. So he had now recurrent multifocal glioblastoma. So at this point, I'm not spoiling it because there is now the indication of starting him on anti-seizure medication. Which would you select? I leave you for like 10 seconds to think about it. And probably this is a European thing, but we go back before I discuss what I would choose. We have a look back what we discussed about the principles of starting a person on anti-seizure medication. So what we have here in Mr. G is a focal epilepsy due to his glioblastoma. So he has a structural etiology. The stage of the disease and life expectancy is not very long because he already has a recurrent disease. And we know that common complications in his disease course will be dysphagia and also maybe disturbance of consciousness near the end of life. We asked Mr. G what his priorities were, and he wanted to stay at home no matter what. And also the place of care would be home with his family as caregivers and also professional caregivers receiving hospice care. The available routes of administration would be oral. He did not have any IV line or pack or port. So this would be the scenario we are talking about. So when we look at the possible medications we could give to someone with focal epilepsy, I would rule out lamotrigine because it's not very flexible. It takes a long time to escalate the dosage. So with his life expectancy and also the available routes of administration, this I would not choose, but you of course could, just because there is the indication for as he has a focal epilepsy. There's also lacosamide which we could use. We could apply it orally There's also a IV formula. It's experimental to use it subcutaneously, so this could be used, but there's only one case report of one patient who received lacosamide subcutaneously, so I would call it experimental. So this leaves us with levetiracetam, which we find now in the drinking water. Because levetiracetam has a lot of or a huge variety of formulations we could use. We have it as tablets. There's a liquid form. We could give it to the patient intravenously. It is possible to use it off-label subcutaneously. There are a lot of case reports showing that that it's quite okay to use it. And there's also evidence, a little small evidence, which leaves it as, in my perspective, as experimental, that you could also apply it rectal. So from my European point of view and my daily practice, I would put this patient on levetiracetam. I would start with a regular starting dosage of 500 milligrams twice a day, and at this point he doesn't have any swallowing problems, so he can have it as a tablet. At this point in our story, he is released to hospice care, just let me talk to Lynn. Lynn, if there is anything you want to add, just jump right into the presentation. Okay, good. Then, as time goes by, and it's not very long, that his symptoms get worse. He has right-sided hemiplegia at that point, beginning aphasia and dysphagia due to tumor localization, and he experiences several focal seizures, which he was aware of and which he found quite distressing, and his wife even as well. So, what could we do, or what would you do? I, as a neurologist, and probably you would agree, is we would give him more of the levetiracetam, and we would change it to a liquid formula, because that is quite a common formula we could use. But when he experiences severe dysphagia and he cannot swallow anymore, we could switch the formula to a subcutaneous use as an off-label use of levetiracetam. And there are two ways of doing so, which can be found in literature. You could either give it continuously, like the whole dosage continuously, subcutaneously, or you could do it twice a day. In literature, it's argued that patients are better off with the continuous way, but I think normally we have to do what's practical. So, and both ways are, of course, off-label, and you have to talk about this with your patients. And then shortly afterwards, he died. So I think hand over the microphone to Lynn again to give us a more pharmacological perspective on that case.
Well, I think some of the difficulties in my practice, which is home hospice care, we probably would not bust out a levetiracetam infusion or midazolam. So some of the big issues are when they come home on an anticonvulsant, but they've not had a seizure. Yes, everybody agrees you should stop it, but how do we stop it? I don't think stopping it cold is a great idea. I think that can precipitate a seizure in up to 30 to 50% of patients. And then, when you look at the guidance, it says, well, you should reduce like 10% a month over 6 months or more. Our patients have a median length of stay of about a little over 2 weeks. Also, as Anna just talked about this gentleman, patients often lose the ability to swallow, even liquid formulations. So Anna, how would you handle that one?
If they lose the swallowing, and how would I handle it?
Would you use the midazolam infusion even at home?
Well, it depends. I mean, it depends on how often he or she had a seizure and how distressing the family think the situation is and how they react on him or her having a seizure. So if I have someone who is kind of quite close to the end of life and only had one seizure, I would taper off levetiracetam and then go on midazolam, for example, or lorazepam on demand. But if I have someone who had continuous focal seizures and seizure series or has experienced status already, I wouldn't do that. I would try to continue the medication.
What we would do probably is our hospice patients have something in the home called a comfort pack or a starter kit. It's a small box with, a handful of doses on about 5 or 6 drugs like morphine, Haldol, Ativan, acetaminophen, and anti-secretory drug, and so forth. So we get an order for the entire box of medications, and the prescriber can either authorize it for the nurse to pull the trigger on that, or if the nurse instructs the family to go ahead and do that. Part of our order set is lorazepam 1 milligram every 5 minutes up to 4 doses to break a seizure. And we use the lorazepam oral intensol, which is a high concentrate solution. It's a 2 milligram per mil. And even in a patient who's completely unconscious, if you prop their upper body up about 30 degrees, you can put up to 1 ml in the buccal cavity, and that works very well. So we use those intensols, which we have available as dexamethasone, prednisone, morphine, methadone, oxycodone. Many of the medications come as these intensols, and that works pretty well for us. But for this gentleman, if he was having seizures, we couldn't do the levetiracetam anymore, we would try to use lorazepam oral intensol around the clock, and then also still have that extra order for seizures that continue. Also, I think we could talk about the rectal route of administration. It's not a popular route of administration, I would say, but I think it's certainly a viable route. There are some anticonvulsants that are commercially available as rectal suppositories. And don't forget, a community pharmacist can generally compound it for you. I see all the most common drugs being compounded by pharmacists. One of the ones that we use probably most often, not only for seizures, but for the sort of kind of palliative sedation, which I think palliative sedation is a spectrum. It's a continuum. I think many of us could use a palliative nap someday. So it's not like 100% conscious versus 100% unconscious. So often we will use phenobarbital for that purpose, and we'll use it by the rectal formulation. So that works pretty well. The other thing that we have in the US is a rectal catheter. So this was actually developed by a gentleman who was a hospice nurse, and he was the on-call nurse. So he always worked overnight. And he got so frustrated when he went to visit a patient who was really having kind of a serious event going on, but they couldn't swallow for anything. And we can't get IV anything in the middle of the night. So he used a Foley catheter and inserted it rectally. And then, of course, he went on to refine that so it would have a balloon that you could blow up as soon as you inserted it to a different area. And then it also has a little device where you can either open the capsule and put the little beads in, or a regular film-coated tablet and crush it, put a little water in there, and then put it in this rectal catheter for absorption. A lot of US hospice inpatient units are now using this as best they can in lieu of IV anything. It's cost saving. It's not as well, you could argue is it as invasive or not, but it works pretty well. Any other thoughts, Anna?
No, I think probably that leaves us some time to also have a nice Q&A and also hear what your experiences are. And I think especially the last discussion showed quite well how there are international differences in routes of administration. So the conclusion is also we have to use what is there and what we're used to and what the possibilities are at the place where we work, and adjust the medication to it.
Thank you very much. So
I was told that in order that Lynn can also listen to your questions, we should use the microphone. I don't know.
Yes, please, yes. So we do have a nice 20 minutes for Q&A. I'm pretty sure you have at least one of, if not 25 questions. And my first question for you would be, what would be your favorite zoo animal to use as a medication? That's a joke. We had the naughty kitten and we have the drunk monkey. I don't know if That's fine. So we have a first real question here.
Hi, I just have a simple question. You mentioned clonazepam in your drug lists, but then everybody talked about lorazepam. Any preferences, and why would you go for one or the other one? For acute seizure, not for prevention.
Sorry, I missed the first drug.
At end of life, she talked about clonazepam, and you talked more about lorazepam. So, is there preferences? What's, you know, both are available. What are your preferences in acute setting of seizure for someone who is end of life, whether he's at home or in hospice? Same, with available sub-Q access, for example.
Lynn, do you want to take this one, or shall I start?
The home care part, and then you can do the acute part. I
Yeah.
do like clonazepam is a little longer acting than lorazepam. I mean, when you look at the benzos, things like alprazolam are way too short, and then you look at the ones that are sedative, they're way too long. I think diazepam is a little bit longer even than clonazepam, so pharmacokinetically, that does give you better coverage. I do think in a home care patient who's really lost the ability to swallow well, lorazepam is going to give us an advantage there. And I'll have
Yeah,
the hospital setting.
Yes, and I agree. And when we are talking about seizures, like we mean status. So when we want to treat the status, we want it to end quite quickly. I would use midazolam nasal if I don't have an IV route, or even intramuscular, because these are the quickest ways. Please correct me, Lynn, if I'm mistaken, but these are the quickest ways of it to actually help the patient and to seize the status. But if if family treats the patient with that medication, probably that wouldn't be handy. So we need the formula that is most applicable and feasible. So if you ask me, I would use midazolam nasal if there is no IV route, and then go to lorazepam as an not as second line, but as like a second choice.
We have midazolam intranasal also in the US. It's pretty pricey, I have to say. So we probably would still try the lorazepam first because it's generic.
Couldn't you just open the vial and put
Yeah.
the fluid into the nose?
Yeah, yeah.
However, you need you need a special attachment for that, and that's not available in every country. But that's something that exists here in Canada, so you can just take there's a little sprayable
Yes.
something with a lure lock that you can put. So that's
Yeah,
another
we
option.
use it for fentanyl sometimes. But my question is to Lynn, what is the onset time of sublingual lorazepam or sub-Q lorazepam in comparison to midazolam? Because I would prefer midazolam because I know it acts fairly quickly. So what would be the onset time for lorazepam?
It is slower, obviously. It's going to take, I mean, even when we do the 1 milligram every 5 minutes for 4 doses, it's probably going to take all 4 doses because it's going to take a while to start to get absorbed. I mean, using the oral solution is going to give you a bit of an edge over a tablet. Although I will say, with the plain old lorazepam tablet, if you don't have the Intensol, you can crush that tablet, and it's very friable. You need to vaporize it, mix it with a little water, make a paste, and put it under the tongue. But you're exactly correct. It is slower onset than midazolam, for sure.
And what would be the range? Would it be 5 minutes, 10 minutes? What would you say?
That take a good 20 minutes to start to get absorbed well. So that's why it's
20. Yeah.
20.
Okay.
we would give
Okay.
it around the clock.
Yes, thank you. Next question.
Thank you so much for the presentation. I work in Australia, and levetiracetam would almost universally be our first line. I just wanted to ask, in the case if Mr. G had maintained his oral route for longer, would you have a kind of standard agent that you would use as second line if you've maxed out his oral Keppra dose? He's still having seizures, but tablets are still very much an option.
Yes, well, personally, I would use lacosamide as an add-on. But I mean, depending on the life expectancy, I mean, lamotrigine would be the perfect medication, but not probably when his end of life is so close. So I would use as a second add-on lacosamide. Lynn, what would you use?
That's your ball game, girl. I don't do acute care. I would call you is what I would do.
And what would you use in Australia?
Yes, what
When you don't have, when people have dysphagia, what do you use for like to cover the end life time?
So from my experience, we're, I guess, a bit more comfortable having subcut medications in the house. So often we would start with sublingual clonazepam and then transition over to a midazolam driver. In some locations, it's quite feasible to have, depending on how friendly your local hospital pharmacist is, to have a levetiracetam driver in the house. And then we can often get subcut clonazepam then as refractory, and then if all those fail, they would be going to phenibut.
Okay, thank you very much. Next question, thank you.
In your case study or example, his wife gave a very good description of his seizure.
Yes.
And
She's very
she
good, yes.
happened to be looking at him when the corner of his mouth twitched before he rapidly went to a bilateral tonic-clonic seizure. My patients aren't always that observant. What would you have done differently had you not known that there was a focal onset to this?
Well, it wouldn't have changed a lot, I would say, because I mean, he had then if she just would have seen him having a seizure bilaterally, that wouldn't have an impact on the later on treatment, because he still would have a focal epilepsy with a like on base of the structural changes due to the glioblastoma. So that wouldn't change anything.
So it's
In this
more
case.
because of the diagnosis, the reason for him having the seizure?
Yes.
Okay,
Yes.
thank you.
And maybe if I could add to that, would be really interesting, and what I've heard from other neurologists is just to, when you don't know what to do, take your phone and film.
Yeah.
So that's usually very good, because this is something that, as we are in panic mode, we cannot know, has it been 45 seconds, 5 minutes? Very difficult. So when you film, you have your clear convulsion, then you can show your very friendly neurologist, and then it's very helpful for them to make the diagnosis and to have a very specific time frame.
Even when I observe someone having a seizure, I take out my phone and stop the time, just to make sure that I have the time correct, and I start treating only after 5 minutes. Yeah. Thank you.
Hi, thank you. I'm from New Zealand, and over the more recent years, I've seen patients on 3 or 4 grams of levetiracetam a day. I'm just wondering, is there an evidence base to that, or is that just simply desperation by the clinician?
Well, that would be the maximum dosage then. And the recommendation truly would be to first use the maximum dosage before you switch. But I don't know the evidence about that, to be honest.
And so for Mr. G, if he didn't die, and if he continued to have seizures, what would you do?
I would first put him on 2 grams twice a day. And if that doesn't work, I would switch to, for example, there was this question before, lacosamide, for example, normally as an add-on, although the recommendation go that you have to switch the whole drug, but I would have it as an add-on.
Thank you. And Marilyn, do you have any other insights?
Yeah, I've not seen 4 grams, but I think we have seen 3 grams a day at home. But I think that's about the maximum. And I'm not aware of evidence higher.
Thank you. Next question.
Thank you so much for your talk. My question is actually a little bit about phenobarb. I unfortunately work in a palliative care unit that doesn't have access to IV Keppra. And so we do have to resort to using phenobarb often, and often we'll do that before we add a regular benzo. And I just wanted to get a sense of, your practices, the dosing, and kind of how long after dosing you would expect to see some effect.
Thank you very much for that question, but I have to skip on that one because I don't use it at all. Probably Lynn can tell us something about it.
Well, generally we start pretty low, like we'll do 30 milligrams like Q8. You can do it as a continuous infusion. I think you can do it as an intermittent infusion too. And as I said earlier, we'll do the rectal. And while this is not very pharmaceutically elegant, and I might get drummed out of the profession, when we get it compounded, I generally ask the pharmacist to make it as 120 milligram rectal suppository, and then we cut it in half long ways and start with 60 milligrams. It's tricky because you can't assure that each half is truly just 60 milligrams. But yeah, we've used all of those.
And as a follow-up question, we actually have it as a subcutaneous option. So that's one of the reasons why we use it more frequently. Is that just a Canadian thing or?
I don't think we've done it sub-Q, but I wouldn't be surprised. If you email me, I actually put together a lovely guide with one of my residents on like the top 40, 45 drugs that we use, parenteral drugs that we use in an inpatient unit, and looking at the alternate routes of administration and what is the data. So I'm happy to share that. I think my email is on my first slide.
Thanks so much. I think you're about to get a lot of emails.
Thank you. Next.
Mel Davis from the US. You know, a lot of these people come with multiple symptoms. So in choosing anti-seizure drugs, so we've tended to use valproate because it reduces the agitation associated with terminal delirium as well as treating the seizures. And it has, you know, we give it subcutaneous. We've given it as subcutaneous infusion. You can also give it per rectum, and then if used as second line, lorazepam. We can't use midazolam on the unit because it's, quote, conscious sedation, so it's really limited to the anesthesiologists, even though we've appealed to call several times to do that. But we found valproate helpful in choosing drugs that one drug that can treat multiple symptoms is, you know, in choosing it and choosing different kind of anti-seizure drugs. So Kepra's kind of a single shot Mauser in the sense that it treats one symptom, a seizure, which is really very important. But I think as a palliative specialist in dealing with people that have multiple problems, you end up trying to choose or to fit a seizure program that actually works well with that. I really appreciated this session. It's been very well done. So thank you very much.
Thank you very much for your insight and comment. Yeah.
Just echoing those comments, excellent session, thank you. A couple of drugs mentioned you cited them as being AMPA inhibitors. And there's a lot of attention now on the role of AMPA receptors and the induction of AMPA receptors as part of the mechanism of treating chronic pain and depression, centrally. I'm wondering if any of the data out there around Topiramax and the other one that I forget which one also inhibited AMPA, that this might make, for example, the control of neuropathic pain worse or might make depression and mood symptoms worse.
I'm not sure. I would have to read up on the literature on that. Anna, do you have any insight there?
No.
But
but now we have something to think about when we come home.
But we do know that this is something that my other specialty is mental health. So I do work on a psych unit. So I do have I would not like to have Keppra on the water because they make my patient with schizophrenia sometimes worse. So that's an issue. So I wonder if that's one part of the story, the AMPA story, might be quite interesting. And also like to think about all the NMDA receptor inhibition, like how does it do? So how would we manage to have like all the memantine with our seizure patients? So that's another question. I don't know if you have Marilyn, if you have like any insights or answers about like using of a memantine for a patient with our seizure at the end of life.
I've never seen it used. I don't know any data about that, but I have to tell you, just in general, I'm not impressed with memantine. Overall.
Well, thank you. Next question.
Hi, I'm Raphael Chan from Ottawa. I work primarily on a consult team in a tertiary care hospital, but some of my colleagues are not so lucky to be there. And I have a question about recognizing non-convulsive status, because usually, we're thinking altered LOC, I don't know, let's go check an EEG, and there's epileptiform I'm just thinking if we weren't in an acute care setting, or you don't have access to EEG reasonably, like a lot of us work at home or hospice or palliative care unit, for patients who are not at end of life and now have obtunded, like often we say, oh boy, maybe like, you know, the traditional thought would be, this is like an irreversible decreased LOC, delirium, etc. But I'm just wondering, is there tips to say, should we look at non-convulsive as an etiology there?
Thank you so much for your question and your comment. There is no straight answer, but it's a very important topic to bring up when we talk about confusion and palliative care patients, because a non-convulsive status is actually a relevant differential diagnosis. And there is a colleague in Austria who had a look at palliative care patients, inpatients, who were confused and who had signs of delirium, and a relevant number had actually a non-convulsive status. But this is just a diagnosis you can find or give to the patients when you have an EEG. So if you have someone at home who is suffering from delirium and who is not in the end of life, you can hospitalize him to find out. That's the only way I can imagine of diagnosing him or of non-convulsive status. But if you have someone who is hospitalized, that's a relevant differential diagnosis to look at, and then an EEG would make sense in my perspective.
And also, just as another thought, just to remember that when we have our patient and we say, oh, this is agitation, if we have end-of-life agitation, then we would choose more of a benzo to use that over first-generation antipsychotics, because a first-generation antipsychotic would be decreasing the seizure threshold, so worsening the situation. We have the time for our last question.
Thank you. Thank you for the great presentation. I was just wondering if you could comment on corticosteroids use, maybe if it has any preventative effect at all on seizures, especially with our patients with brain metastases, for example, and which one you would use at what doses?
So when we talk about steroids, we talk about anti-edema therapy. And sure, that might help, like in an indirect way, but I don't have any data on that. And we wouldn't use steroids as an anti-seizure medication, but we would, of course, use it as symptomatic and supportive medication. And then I would use dexamethasone. And there's no data whatsoever how much. So there is this ongoing conflict between neurosurgeons and neurologists about how much you should apply. The neurosurgeons would use 3 times 8 milligrams as a pulse and then taper down, whereas neuro-oncologists would cry out and say, no, that's far too much. Let's just have like 8 is enough, and then you taper down. So I would use fortecortin.
Thank you.
We have a saying in hospice that nobody should die without Decadron on board. Maybe that's a dexamethasone also because of the long half-life. It's about a 60-hour half-life in the tissue, and it has the least mineralocorticoid activity, and it comes as a liquid intensol. Rock on.
Do you have any conflict of interest with Intensol, Marilyn? Okay. Okay, so thank you very much for this very great session and very great participation. Thank you very much. So now I'll invite you. Does this work? It doesn't. Okay, so now I'll invite you to go to the Innovations Challenge at 519B. If not, the other conferences will be back at 2. Thank you very much. And for the credits, 1849 for the credits. Thank you.
Then I think about
about that, and
I can-
that is so logical.
I can
that
forward
we-
you the paper.
Yes, and the other thought is we have is,
Thank you very much.
I
don't know.
that worsen delirium.
Sorry, I'll get.
That's really nice of you.
Thank you very
Mais
much.
c'est peut-être pour ce mécanisme-là que les antipsychotiques aggravent le délirium en fin de vie. Parce qu'on a des études qui ont montré des augmentations de délirium en utilisant de l'aldol expérimental. C'est super intéressant. Oui, on part là. Moi, je l'ai fait une fois parce que j'avais une super bonne raison et que j'étais capable de convaincre mon boss de m'envoyer du film privé. Mais. Non, mais on donne. Des fois, on l'avait donné en suivi, mais normalement, on donne du film.
Yeah, to be honest, like my experience with phenobarb is like zero.
C'est ça que je me rends compte.
In neurology and non-palliative care.
Pas, je pense même pas qu'on a.
I found that there are two and there was just very like
Ah, ok. Ah, enchanté. C'est que j'ai pas de temps protégé. Mais oui, c'est que dans le fond, mon temps protégé est plus en psychiatrie. Mais oui, je fais de façon idéale de ça. Je travaille au Jewish. Au Jewish en psychiatrie. Puis je fais aussi des heures de fois au Mont-Sinaï. Mais aussi tout ce qui est clinico-administratif à l'hôpital général, c'est moi qui fais.
I know, I mean, I have to say, it isn't limited.
En fait, on utilise la sélection
Yeah, they're not a lot.
c'est juste que l'accessibilité peut être difficile, mais clairement, on a besoin de réfléchir à nos pratiques parce que... Ah ouais, non, on fait jamais n'importe
Thank you very much. Let me show you the
actually, you do have you should have my email because I am the co-chair with. But let me give you.
Wait,
So
I'll have it here actually.
yeah. Oh, that's perfect.
No.
Oh, that is so nice to you. But I this is
If
brilliant.
you want to write it
Yes.
down
Where do you?
or take a picture.
Oh yes, that's perfect. I just take a picture so that that's easy. No, don't put it. I think it's easier if I just take a picture. Yeah, but I will find it. But thank you so much. That was really nice. Yes, I know. But it's a subject that it's really we find that it's difficult to relate. So it's why it's so interesting to have a neurologist that have also palliative care experience. Oh, thank you. Thanks. Sorry, I was trapped in the corner. I couldn't get out. I just had a question about medication for ADHD. Yeah. So say someone has a seizure, which is their first issue, and they don't know, say, the beginning, then they have surgery. So theoretically, would you still do that? A lot of our neurosurgeon problems with them keep patients on Well, the problem is, in this case, like when this happens during surgery, you could also call it an acute seizure, like a provoked seizure due to the surgery.